Well, welcome. Thank you for
Thank
joining us.
you.
I'm just going to introduce you to everybody. Tonight,
Sure.
we are pleased to feature Dr. Devi Bhuyan,
Bhuyan.
who is
Mhm.
the Director of Psychology at Shepherd Pratt. She previously served as Senior Psychologist at the Menninger Clinic and Assistant Professor at the Baylor College of Medicine, Houston, Texas, where she worked at an inpatient unit for personality, complex trauma, mood, anxiety, and comorbid addictive disorders. Beginning her career in the nonprofit sector, her professional experiences include addressing domestic violence and sexual abuse in India, as well as capacity building of human resources and developing fundraising strategies. Dr. Bhuyan received her doctoral degree in clinical and school psychology at JMU. She completed 2 postdoc fellowships, the first at the International Beliefs and Values Institute, whose mission is to explore how beliefs and values influence actions, policies, and practices. Her second fellowship was at Baylor College of Medicine and the Menninger Clinic's Compass Young Adult Program. She has also worked and trained in a variety of mental health institutions in India and the US, serving a range of diverse populations across the clinical and developmental spectrum. She continues to work in IBAVI,
Mhm.
yeah,
Yep.
initiatives, and is currently working with an interdisciplinary team on an MMPI-like assessment tool called the Beliefs, Events, and Values Inventory.
That's correct.
Welcome. I'm
Thank
sure we're going to
you.
hear about all of that. We're super excited
Oh.
about you.
Thank you so much for joining us. It's really a delight to have you here. We're looking forward to hearing all about your work. But just to kind of get started, Devi, why don't you tell us a little bit about how you got into this gig and what inspires you now and what you want, and then we'll talk about your work. So tell us
Sure.
a little bit about your journey.
So I think if I really start, it is when you have mental health issues in your own family. And I have an uncle who's now in his 70s who had serious mental illness, and his behavior made me curious. Why was he doing some of the things he was doing or saying some of the things he was? And then, school, college, continued to be interested. And then I started work on looking at violence or trauma, right? But from the nonprofit sector, where we were looking at the laws. So there was a legal component. There was finding women who were going through experiences of either domestic violence or survivors of child sexual abuse, finding ways to counsel to some extent, but also provide help, get them out of the violent situation, find housing, find work, figure out how they can be independent. And I remember we had a rather successful case. And after all that was done, found housing, found a job. I remember this was a colleague of mine says, she's depressed. She was like, I'm grieving the fact that, the fairy tale I had, like a marriage, my husband who was supposed to be loving turned out to be violent. And then I realized that we were kind of ill-equipped to handle that, right?
Mhm,
That
mhm.
final thing of grieving and getting her to process this information, and activism doesn't teach you that. Activism is a lot of emotion and get things done, but that slow work. And I realized I'm temperamentally more suited for that slower, longer work.
Mhm.
So by that time, I was already 30 years old, and I decided to train really to further understand this, right? Understand us, that when things supposedly are a success, why we still not feeling that great about ourselves. And I wanted an from India. When you look at, the US is supposed to be this is at the heart of psychology, and a lot of our readings come from the United
Mhm.
States. But it's very specialist, right? You have to be an OCD specialist or an eating disorder specialist. And in a country like India, you have to be a specialist in everything.
Mhm.
you cannot be so hyper-focused because it just doesn't work. So I was looking for a generalist kind of program, which is how JMU, which has it's I think 11 schools, which is a combined integrated program. So combined clinical, counseling, school psychology, 75% of our curricula is really, they overlap and there are these minor differences, right? As well as theoretical integration. So I think it was a really good fit. And with you, Jeffrey, that's how I actually met Jeffrey in one of
Yes.
the conferences we had. We were not only talking about theoretical unification, but we were talking about how do we as psychologists, we have a fund of and a wealth of information about how we tick, but that psychology is missing from activism or from these what we call these wicked problems, whether it's the environment, whether it's politics and policy, religion, gender issues, things like that. And so we became very fascinated, and that's how I tried to wed both the activism and all these problems of the larger world with the microcosm of, just doing the basics of psychotherapy. Of course, it's hard to find a job doing this, right? And being that interdisciplinary, you have to be a specialist. And so we tried for a while, and that was my first postdoctoral fellowship. I also worked as a visiting professor for a little bit, but eventually had to find something, and I was lucky to find a postdoc at the Menninger Clinic. And Menninger Clinic historically was based out of Topeka, Kansas, was a psychoanalytic hospital and institution. But as managed care changed mental health practice, it found that, those long-term hospitalizations no longer work. So the level of severity, co-occurring disorders, a lot of personality issues, high levels of suicidality, high levels of some kind of substance use or addiction, eating disorders. And so the postdoc was what we call a psychotherapeutic hospital, right? And a psychotherapeutic hospital, so you have 24 hours of nursing care, you have internal medicine, you have psychiatry, but with psychiatry, you have a team of psychologists, social workers, addiction specialists, and this team works together to first explore comprehensively from all these different interventions, right? To come to a comprehensive diagnosis. And Jeffrey, you talked about core issues in our last, and we use the same terminology, core issues, the core problems to figure out why is this treatment resistant. And these sources come from your family, developmental factors. And so it's multimodal, but integrative in this way because we're using the information we get from the patient and the patient's interactions. And it typically happens, a patient comes in, right? It's a very milieu-based model, milieu therapy, and replicates or recreates the same dynamics, and it gets replayed. But in this setting, because of nursing and this 24-hour care, we are able to observe it and use those observations in our various therapies to address and get to these core issues, where sometimes in an outpatient setting, you just don't have that advantage, right? So that was fascinating to be in a psychotherapeutic hospital where medication management and all were a thing, but it was really all these different, and lots of group settings, a lot of, yes, psychoeducational groups, individual therapy, but group therapy, and then family work, skills-based training. So that's what I did. And as a psychologist, one of the key roles in this model was you did the assessments, you did psychological testing, but during the diagnostic conference, which would happen, so then long-term treatment became 6 to 8 weeks. And now it's even, with
or shortened.
increased costs, it's even shrinking to 4 to 6 weeks, right? But the 6 to 8 week model was at the 4th week, the team would sit and review all the data, including SCIDs and psych testing and group and nursing assessments and everything. And we would review the treatment, but we would outline these core issues. And we were like, core issues are much more important than your diagnoses. Diagnoses are from clinicians, but for you, it's these core issues that will feed into your treatment planning. And the psychologist was very crucial in conceptualizing the case.
Oh, wow.
And that case conceptualization, for me, I thought it really helped because I was integrative. A lot of my colleagues were psychoanalytically trained, very psychodynamic. But the change over a period of time with Menninger was that because of all these different disciplines, we had skills training for DBT, right, or ACT strategies. And so therefore, patients got that psychodynamic understanding, and especially Peter Fonagy and the mentalization-based treatment. He was a regular consultant. So that really helped wed the cognitive behavioral strategy with attachment and mentalization, and take that developmental psychopathology perspective, right? And so I found that some of the most rich clinical experiences.
So I love the fact that it was so team oriented. I think
it was so, yeah.
I don't think that we can do good work if we're not in a team, especially for complex patients, that kind that you were getting in the hospital. How, for those of us who aren't in hospital, like Lizzie's in a hospital setting, but I'm in an outpatient setting, and what do you recommend for those of us who are in outpatient settings and working with people who may be on the border of needing intensive outpatient or maybe even inpatient, but they might be able to benefit if we can intensify it? What do you think we could do to?
So I'll tell you ideally, and I'll tell you realistically. Right?
Two different things.
Ideally, we thought, could we replicate this, right? And could we have like a private practice where there are these offices of a social worker, an addiction specialist, a psychiatrist, a psychologist, and then whoever gets the patient does their bit, and then we refer like, oh, but you need to meet the psychiatrist for this. Oh, we see an addictions component, we need to do this.
Yes.
And then weekly at least meet, so we're discussing the patient, and then formulate something that can be replicated in a similar outpatient model.
Yeah.
But I have heard from my colleagues who are now in private practice that it is difficult to do for a variety of logistical reasons. And Elizabeth, you may have some, or Jeff also, why it's hard to do. But I think then realistically, for example, now a lot of my, it's really hard because the costs of running a hospital like that are very high.
Yes.
Right. So you're barely making ends meet. Patients also find this a very expensive treatment.
Yes.
So we're constantly getting pressure to downsize, make it simpler, make it quicker. And that leads to a lot of burnout. So I have a lot of folk who've left and are doing private practice. And so back in Houston, where now the clinic is, they refer to one another. So if testing is required, then they will refer and, get that information that informs their treatment planning. So I am sure you have your own referral sources, and that can help in managing all the different needs patients have. And I don't know if you all call them clients or patients, but we had this big, I want to take a minute to sort of why I prefer the word patient. I don't know what it is now, but per day, I think now it's about $1,700 to $2,000, right? Which is typical of hospital stays also like that, except this is private pay. And so very rich people tend to be able to afford it.
Yes.
Unfortunately, that's one of the downsides.
Yes.
And one of the problems with rich people is that they think money can solve everything. So there's a lot of entitlement we're dealing with. And because of stigma and this pressure, there's a pressure for us to provide customer service, which becomes like as if we're a hospitality service, right?
Yes.
But we're treatment providers. We're in treatment.
Yes.
And there's a difference. We have to make the environment safe, comfortable, all that, but we're not a hotel, right?
Nope.
And so we really push to say that the patient means we're working on treatment and we're providing feedback to help with your treatment. And so with some of my trainees and all, when I have that conversation, they still feel uncomfortable, right? Because I think the younger generation is much more sensitive about language and what they mean. But my rationale, especially for the kind of patients we see and the residential level of treatment where they need, and these are very suicidal, their self-harm is something that cannot be managed outside. That's why they're in. And so that is why I sort of, stay patient so that they know that they're here for treatment. And our interactions are not that we're providing a service because we're a hotel or it's like hospitality. And we would have patients saying, why are you giving me this yogurt? I want Icelandic yogurt and I want crepes from, which was all symptomatic of some of the personality issues.
Yes, yes. All diagnostic.
Very diagnostic. Very diagnostic.
So it's interesting. We all three of us work in different settings and share a lot of the same ideas. So my setting is I tend to work, so I'm out of network, so I tend to work with wealthy patients. And we just did an interview 2 times ago with someone I work with very closely, where we have that kind of team approach. And I find that we are so trusting of one another and so able to work together that we've gotten to the point now in our work where he's a psychiatrist, I'm a psychologist, and he's a psychiatrist that believes in psychotherapy, the value of it. And so what we do is we do that kind of assessment together, and sometimes we'll call other people to join our team. So we have a kind of a morphing team depending upon the patients. I might have it like with another case, I might have a child therapist that comes in, or we have a great neuropsychologist that we work with. And so we do have this team, and we all trust one another a lot. And what I think has allowed me to do my best work in my career is that we are collaborating sometimes a couple times a day. And sometimes even when each of us are with the patients we share, we will call and talk, the 3 of us or the family, in a way. And we have found that kind of collaborative team approach we don't have any empirical data on it, but the kind of feedback we're getting and some of the follow-up we're doing, patients do so much better when they have a team who are working together. Most therapists in private practice don't even get back to you. They don't even call you back. Or I'm not just saying therapists, medical professionals.
I know. And when I left Menninger to come here and applied for this, part of me was like, should I try private practice? Where will I get another opportunity? And then this position opened up. And I continue to, emphasize teamwork. And for example, a very severely personality disordered who splits,
Mm-hmm.
right? And emotions, right now it's happening right as we speak.
Yes.
Emotions are activated because very difficult. Other patients are complaining, get them out, right? And not that, and so certain pathologies, the splitting is, they're just like wizard level good at it, right?
They're professionals at it.
They're professionals at it. And no matter how skilled you are, we get split.
Yes.
But even then, to manage the
Tension.
emotional, that affectivity,
Yeah.
nothing better than a team with humor.
Absolutely.
They're driving us crazy. This is happening.
Yes.
They're,
It's a kind of co-regulatory body that absorbs and metabolizes.
Exactly.
So we don't fall to the projections and feel terrible about ourselves. I think it's critical what you're
Absolutely.
talking about.
And this would frequently happen because, and Elizabeth, you might resonate with this. In our roles, the LCSW, the social worker, did the family work, right?
Mm-hmm.
And had the toughest job because they'd be frequently devalued because, one, they're not the doctors, right?
Mm-hmm.
Somebody with that kind of pathology will devalue someone like, oh, I only work with doctors. So we had to handle that.
Mm-hmm.
Then they were the face of the family, and families like, I need to speak to the doctor now, and da 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 da. So they would have to face that and shield us from that. And frequently, because of the split, they would be devalued because of the family and what the family was complaining and managing that.
And the doctors are idealized.
And the doctors are idealized. The therapist, the individual therapist, is idealized. And so I really, and some of the best social workers, right? I really, really appreciated the amount of work they did to manage the team. Because it's not fun when you're devalued, de-skilled, and all the tactics that they use sometimes for that person in the team. So and some levels of pathology, as we talked about, was really difficult. Even nursing, because nursing is frequently in the role of telling them what not to do,
setting limits.
Do this.
Yes.
Setting limits, enforcing the rules. And we were in a hospital. JACO would come and, investigate. And so there were a lot of rules that even we didn't like, that
a lot of
we
pressure
had to enforce. So for all those things. And then, one of the things at Menninger we did were outcomes assessments, right? Every 2 weeks from admission, 2 weeks, till follow up for a year. So we also knew,
that's amazing.
And 75% treatment worked, but there was a 25% population where it wasn't working.
That sounds pretty high, though.
It is.
That's pretty effective.
Wow.
It's pretty effective, but you always think of the 25%.
Well, but that's much better than almost every medical treatment. Most medical treatments don't get that kind of result.
Yeah.
I don't think at my hospital.
And the follow-up especially, because then we would mostly send, especially my unit, they would go to a step-down program, because once they community reintegrate, they still need the scaffolds.
Yes.
Right? Because they would go back and sleep all morning, not make it to class. Structure. So you needed sort of the behavioral activation and some of the supports they had. But what we also noticed was initially they would come right? They would get used to it. And within the first week, great improvement. So we were like, why is, and then again it slips, right? And the first week, one is provision of safety. Immediately they're, in a safe environment. Promotion of physical health, when you sleep, when you get up, when
Yes.
you
Yep.
eat, right? Structured activity.
Structure.
And, and we tried to follow the 5-day-a-week thing. So a lot of programming and then downtime during the weekends, right? Then, hospital regresses you. You don't have to cook. You don't have to do a lot of things.
Oh,
So that kind of regression, right? For people who feel so overwhelmed, they cannot function. The stress of that would make them feel better because these things were taken care of. And then the social engagement, right? The
Yes.
fact that they weren't
They're not
feeling,
isolated.
a lot of the thing is isolation, feeling alone, feeling alienated. And so the social engagement, and I've noticed, especially in group therapy, the feedback they get from peers is much more powerful than what we were doing.
Way more important to them.
Yeah.
Yeah.
So we'd have a lot of that, and just sort of the behaviors. And I was in the young adult unit, so there were, as we call it, a lot of shenanigans that would happen that we would have to, address and remind them, because frequently when we did set a limit, they would tell us how prison-like it was and expect punishment. And we're like, we're not punishing. We're not, there to monitor everything. We're here to point out treatment interfering behaviors, what's getting in the way, understanding your dynamics, how you show up interpersonally, what's getting in the way. So that was what a lot of my work was.
So can I ask you, what are the challenges of providing psychotherapy in that setting?
One is, if you're used to working on your own, sharing the patient and some of the boundaries, because something that we were talking in your individual therapy would also come up in, say, the addictions work and who's doing what, right?
So how do you deal with, so is there, when early in my career, I worked in a milieu-based hospital that was heavily devoted to family therapy and group therapy. And the way we did it was we had what we called a administrative therapist split. So there was an one of us on the team would deal with administrative stuff, and we tried to preserve the therapeutic relationship, but it doesn't seem like that's very useful to have it so you can't use what the patient and the therapist learn in the team. How do you manage?
One of the things we did was that we were all in teams. It was led by a psychiatrist. So, it was their last names. It was Team Davidson, Team, but the psychotherapy would be frequently to somebody in another team, in the same unit, but in another team. And the reason for that, it has its pluses and minuses, but because so much of the work was shared, especially there was a lot of feedback you gave to the family. Individual therapy was slightly separated out and made into a kind of sacred space. So you can, all these feelings that you have, you can talk about it there. And it would be really interesting because you wanted to share, and we would say confidentiality also means the team. So, for example, I remember I had a young adult who hid the fact that she gave up a child for adoption. Okay. And one of the reasons she wanted to first address it, all the feelings around what it was, and not tell her family about this grandchild, biological grandchild that they had. And she wanted me to keep it a secret from the rest of the team, from the attending, the social worker. So when I was in, situations like that, I'll say, I'll hold it for now, but I'm going to work with you to be able to tell it and not keep this a secret.
Okay.
And I would tell the team, there is something I'm holding. I just want you to know.
Oh,
But
interesting.
I'm
But
not.
respect the patient's.
I want to respect the
Mhm.
patient's,
I like that.
desire for a bit. But I'm working to get her into a space to be able to tell
Sure.
it to
Yeah,
the
good.
whole team.
You're a good therapist.
I
So
like that.
sometimes it was, these tricky things would.
These are challenging.
I have a question about so the hospital where I am, it's an inpatient acute psychiatric hospital.
Yeah.
And we don't do any family therapy.
I
We
know.
don't do any, there's no individual. So I mostly do group therapy. That's
Yeah.
what the majority of their treatment is. I think the social workers are supposed to, but they're just overworked. They have too many cases.
Because of psychosocials?
Yeah, they do the psychosocials.
Yes.
So
Yes.
I am a social worker, but I do the group therapy. So we can kind of give them individual therapy, but there's no private place to do that. There's just one room. So how effective do you think hospitalizations can be without
It's
family
an
therapy?
excellent question.
Without multimodal, you're saying without a full component of multimodal
Yeah, it's
therapeutics.
lacking a lot of the modes.
So
individual.
This is, Jeffrey, this is another thing I wanted to talk about, right? Now, Shepard Pratt, again, a very storied, much older than
Yes.
Menninger,
Yeah.
right? Moved in the 80s to a managed care model. So besides some specialty services and a residential program called Retreat, the rest of it, 2 hospitals, are the managed care revolving door acute involuntary model, right? And for some of those who are in crisis and need that brief hospitalization, it works. But there's a huge, especially people who, feel suicidal and are just, and then they, and borderline personality, right? They get suicidal, then they don't, and then they discharge, and it's a revolving door. It's a problem, but it's a systemic problem because until managed care provides us the codes for billing services that happened in inpatient other than the psychiatrist, and there's, I think, a social worker for some areas, right? Other than that,
that's it.
Hospitals such as Shepard Pratt, which is only psychiatric and don't have surgery departments that usually can swallow the costs. It's really tough. So I've heard that in Colorado, there is an in-between inpatient unit. So there's acute, and then from acute, they step down to an inpatient where the psychologists and occupational therapists and social workers that's doing something, and then they're discharged. This is not the case here. But I think that model would be realistic, right? And being very close to Washington, D.C., and knowing some people in government who work for Medicare, Medicaid. Now, a lot of our patients in these outpatient services or inpatient is Medicare, Medicaid, right?
Yeah.
And those are big costs. So, but if we could work this out through addictions, I think now I think the Biden administration is trying to do something, but if we could, then we could get some of the psychotherapeutic people to
the
be in these
politicians
settings.
talk a lot about when I hear them talk about how to address gun violence, they always say we need mental health, but they don't
do
anything
for it. They
right.
They talk
They
about
invest.
They give lip service to it. And we do, I mean, I think you said something that I think is important to underscore. You were getting excellent results in a multimodal team approach, a comprehensive, pretty brief program, right?
And even briefer now.
Yeah, but when you look at, so that cost for that 8 weeks, what are the cost offsets of that in terms of violence, in terms of all the things that we look at when mental health is impaired? So I don't understand why we can't figure out how we can fund what everybody talks about wanting to fund, but they don't, like mental health.
Yeah, if a part of me, when I sort of envisioned this job when I was transitioning from the Menninger Clinic to here, was like, how about going to APA? It's right here, right? I'm in DC often. How about going to APA to lobby for psychologists? Because psychologists are increasingly going for the private pay because
Yes,
it
yeah.
sucks, right? The reimbursement rates
Well,
really suck.
so what I think what it has happened is that we have followed the medical path
Exactly.
that now in medicine you get, if you're going to get a mid-level provider, and now in psychiatry and psychology, almost all the people on the plans are mid-level providers, and
And
most of the
nurse
doctoral level,
practitioners,
right, and all the
psychiatric.
doctoral level people are like me are out of network because I couldn't really afford to.
You wouldn't make any
You know,
money.
yeah, and to support a family, to continue my training, continuous education.
Doesn't make sense.
So we have at least a three-tiered system. The people who can pay, the people who have managed care, and then the people who don't have anything.
Exactly. And so what we're doing in Shepherd Pratt is we have these specialty services that are not, I mean, we can provide a bill, and insurance may or may not reimburse, but for us it's expensive, but it helps us keep the larger organization, because the overheads for any inpatient hospitalization stays are very
Yeah.
significant.
But also when you look at what the burden that is being placed on the emergency rooms in our country, because all that money that's being spent, I just had a patient who was admitted to a hospital who spent 5 days in the emergency room.
Yes.
A kid, there's
I
no
know.
bed. 5 days.
And like
Yes.
in the hallway or something.
Basic
Yes.
in the hallway, and
Yes.
restrained in a chair, and 5 days, and
I've heard 10 days, and now, Shepherd Pratt has started, it's called Psychiatric Urgent Care, PUC or PUC. And that is to work with the emergency departments in different hospitals in this area to shorten that. So there's a straight, and there were lots of barriers, right? And we're just sort of working to reduce that. And the other part of it is that as acuity is increasing, other problems, violence directed at staff, right? Nursing post-COVID and this exodus of nursing.
yes, yeah,
All that, I mean,
the perfect storm.
So perfect storm. And we really, like, if you sometimes sit in our thing, you'll hear the code green, right?
Oh, yeah.
Aggressive patient, and not having enough staff, people working double shifts. The other thing was now the agency nurses. And for an organization, and again, a lot of complaints about agency nurses, unlike long-term nurses who know their units, know the people, right,
Yes,
and manage it. So these are big problems in
systemic.
inpatient.
These are systemic.
Systemic issues.
Oh, yeah.
And
how do you think we can't prevent it, but how do you think we can reduce burnout in our clinicians? I just saw there was an article in one of the psychiatric journals. I didn't read it yet, but I saw the headline was the high incidence of clinician suicide.
Oh, yeah.
what are your thoughts about how we
My
can?
thoughts is, again, like, we need to systemically change. We need to pressurize managed care. So a few more services because they'll say, oh, this, like, I've also, like, in day, we have a lot of partial hospitalizations, day programs,
Yes.
right? But in day programs, you cannot charge for, supposing you take the patient out for a 40-minute individual therapy session, you cannot charge it
Can't
because
charge.
that's a different level of care,
Hmm.
right? So mine is, we really need to rethink and become a little more political. I think psychologists, we are so sort of, we love the therapy work that we forget the larger systemic issues. If we take Bronfenbrenner's model
Yes.
and really look at what are the systemic issues that's resulting in this, where we're forced into I won't say forced, but the option,
Gently
we're
pushed.
gently pushed into private practice. And you
Yeah.
hear a lot of folks saying, I want therapy, but I can't afford it
Yes.
because it's too much.
And then we have the rise of all the better help. What are some of the online?
Better
Health.
health, right? There's better health.
No, not better health, better. Well, yeah, the big online.
Where you can do like phone therapy or text there. My friend did
Yeah,
a
yeah.
text therapy session.
Better help, I think it is
Yeah,
one of
BetterHelp.
the big ones.
Yeah,
That's not therapy.
yeah, and it's very different. I mean, I just recently did an assessment with a patient, and the pre-screens were all on Zoom. I walk into the room, I look at the behavioral observations that were not as noticeable virtually, and the whole tenor of the change. I was like, no, we need to get this. This is what it is. So it's very different when we cannot always. And for some elderly patients who can't come, a hybrid model, some
Yes,
telehealth
yeah.
Mm-hmm.
versus.
It has its advantages and benefits, but it also can be overutilized in a way that is not helpful.
Yeah.
So, but getting
But
back to
I'm really glad to hear your teamwork, because that also gives us information about, patients can show up very differently with different providers.
Oh
Oh, I
yeah.
didn't see that at
we're
all.
triangulating when we get multiple perspectives, and then as the team, we're trying to work it out so we can fine tune. Like when we're talking about the core issues, what is the core? What are the core issues, and what's the deep code that the person is expressing that is not apparent when we have multiple people interacting with them?
Yeah.
We can run it by our team members. It's wonderful. So, but I wanted to get back to burnout, because I think for
Burnout,
me,
yeah.
Devi, I think one of the things that inoculates me from burnout, because I work with a lot of very uh, severely disturbed patients,
Mhm.
and carry a lot of weight with many of them. What keeps me from burnout is my team.
I was going to say the team,
My
which is.
relationship with, I can call my colleague anytime. He'll pick up the phone. I can say, what am I going to do? And he can do that with me. And so we have people who I know are there, who have my back.
Talking about team, and I'm just going to share this, is a colleague of mine developed a game which is like Monopoly,
Uh-huh.
but it is about admission into, the clinic
Uh-huh.
and going through, right? Going through the whole
Process.
process, and it is so funny because it is based on, so you roll a die and then you get there, and either you get, you can go
You
forward or
get
you
there at
go
the night
backward.
when no one's there, or on the weekend when no one's there. You get there
Yeah.
Monday. Yeah. Wow, that's
Monday
interesting.
morning on a holiday.
Can you
Yeah.
share that with, or is that proprietary?
Exactly. So this game that she developed, like Monopoly, I'll just show it to you. It's, I don't know if you can see it, right?
Oh my
That's
gosh.
cool.
Is that available?
No, it's just a joke amongst us,
Oh,
right? That would
it
be,
looks like more than a joke. It looks like something that would be very useful for learning.
yes. And so, like, I don't know if you can see it,
Oh,
but you
Oh,
roll
yeah.
it
Oh
and
my
then you go
gosh.
forward, and then what a typical 6 to 8 week program is, and what
oh, that
happened.
looks awesome. She should get that out there.
That should be developed.
And so we had a reunion recently, and we had so much laughter about all the things that happened. And, we always have some like Hall of Famer patients, right? And we just,
Isn't that what inoculates us against burning out? Because the
absolutely,
work is it's
Heavy.
I think for many of us, we've talked about this before, it's a calling and it's a privilege but it's got a lot of burden to it.
it's got a lot of burden. And I think the team, especially sort of the elders, right? And we had some seasoned folk there. And the minute we'd get too activated, just calm down. If somebody
Mm.
threatened to sue you or whatever they did,
Mhm.
just bring
Mhm.
it down,
Yeah,
right? And so I cannot emphasize teamwork. Even though we would fight, we would have disagreements, we would get split, you know, it was all part of the work. It was never boring, it was never dull.
that's another aspect of it, I believe, that we're always learning, which is amazing to have a career where you
Continuous.
never stop learning,
Exactly.
hopefully.
Can't stop.
And the other, sorry,
Go ahead.
Elizabeth, did you want to?
No, go ahead.
No, I also say the other aspects besides work is community,
Community.
hobbies, family, things that you like. It shouldn't be all consuming work. You
Yes.
should be able to switch it off
Yes.
and enjoy friends and family and hobbies and outings, whatever they are. So that balance has to be there, And I remember the first year, because typically this would happen where a patient would, in group therapy, would just say the worst things about you, right? And as an early career person, you would take it home. You're like, I should have said that. I didn't do this. And then you get used to it and you realize that's part of the pathology and that's part of the treatment. And
Hmm.
there's learning to be done
Personal.
from that.
Mhm.
Hmm.
So, to have trainees, early career, mid, and senior all work together and see
Yes.
that even a senior person can be absolutely devalued and pilloried, right? That helped us when we were young, because then you
Yes.
realize this was also the pathology. It's not necessarily.
And also that way that none of us, no matter how senior we are, we still have doubt, we still have insecurity, we're dealing with uncertainty. The number of decisions that we make every day, from little ones to life-based ones,
Absolutely.
and
And
and much of it we don't have any empirical data. We have to do that based on some kind of uh, decision analytic thing that we do based on our experience and our knowledge, and trying to figure out harm and benefit, and rapidly all day long making those decisions.
absolutely. And I want to also highlight the failures. We've had suicides in the hospital,
Yeah.
right? And that is devastating.
Yes. How do
And
you deal with something like that as a psychotherapist, psychologist that's in the hospital when you have a patient that commits suicide? How do you deal with
it
that
is
as a
awful because the trust, right? Where typically, they lie, they say they're safe, and actually they were hiding the level of suicidality. And we go through like, what did we miss here? What did we do wrong?
Mhm, mhm.
Right? So we've had, I remember during my time, there were three suicides in the
Uh-huh,
hospital.
uh-huh.
And it was really, and what helped was we would then have process groups
Postmortem.
for, places where we processed, so we could talk about this and normalize it. And I remember Dr. Ellis, who is retired now, and he did a lot of work on, CAMS, the Comprehensive Assessment and Management of Suicide. He had brought that in. And he says, look, cardiologists and cardiac surgeons have deaths too, right? This is the nature. So he would normalize, put it in perspective and say, we are going to lose. We're not perfect. Our treatments are far from it, right? Sometimes it works, sometimes it doesn't.
Yes.
And that's the nature of it. If you are working with suicidal people, you are going to
have a suicide.
Have a suicide or two or more.
Yeah.
So, and some things were really painful. For example, for very severely substance users, that last hurrah. We used to have a lot of people who would say, before I commit to sobriety, I'm going to have one last sort of party, right? And then overdose and don't make it.
Mm-hmm.
Yeah.
Right? Or relapse so badly and say, we're coming into treatment, but in the few days between I'm coming to admission, that has happened too. We've lost, patients.
So we can see you're passionate about this work. What is it about this work that makes you so passionate and inspiring? I can tell. I mean,
It's by the way you talk about it. Yeah.
is passionate about it, and you're clearly passionate about what you do.
I think I felt very lucky to have the privilege of working in where I did, and to have the people who mentored me. Craig is a big part. Greg,
Yes.
in sort of helping me understand this. And I feel
we can do a shout out for them. Do you want to say their last names?
Greg Sheely, Greg Henriquez, and the team at JMU, not really well known, but what I got. And for me, it is having this understanding of who we are as humans. Times are tough. Like when you look at politics, I also, like to know what's around the world, what's happening to democracies and things like that.
But the allostatic load is tremendous.
Yes,
right. When you just watch the news, it's
awful.
Awful.
But I think this is what makes me feel passionate and a little disappointed, because I think we understand the motivations of people, what makes them, what's happening, beliefs, values, how change is so difficult, how hate and shame doesn't really work. And, so all those things, but I think provides the passion. But at the same time, I wish we were better at expanding and being more interdisciplinary and having psychology and the insights we have with other disciplines, because some of these issues cannot be, it's not one discipline alone. We just need the expertise and knowledge of others.
So can you say a little bit about your any work you're doing in the values and beliefs sector right now?
What are we doing? Most recently, we've been writing books, and the last book was about, it was walking, not book, a book chapter, was looking at what are the elements in what they call transformative education, right? So this is Freire, Paulo Freire in that work. Like, how do communities change? What is transformative? So this was like a breaking down of silos and bridging different theories and different, so education, psychology, and sort of looking at whether we could crosswalk and understand it from different perspectives. That's what we did last. I continue. My husband, he works on issues of environment and conservation, right? And so being informed by his work, but also me informing his work. Like, you have to look at people's needs. People are not just destroying their environment because they're destructive. People are using the environment for their own needs.
Yes.
And in ways that may be thoughtless sometimes, but it is to expand and understand sort of how humans impact the environment instead of and if you think about it, if you look at conservation issues, they largely came from biology, right? Conservation biologists. And now we're sort of challenging that dominant paradigm and saying that, and for example, why do we have climate change deniers, for example? What's the psychology of climate change deniers? And with your work with Craig, how much his research and what he's doing have informed what we understand of why there's climate change denying, or what are the kinds of personalities that are more open to.
So do you and your husband collaborate?
Very little. Like, for example, at Loyola University, we gave a joint talk.
Oh, wow.
About, he talked about like his, there was the area where he researched, it's a tiger reserve. And reserves are different from national parks because in reserves, human activity is allowed, unlike national parks where that's not allowed, right? And so he was looking at logging, poaching, right? And who benefits from that, right? The person who's actually cutting the tree is just getting a little money. All that furniture is going to big cities, in this
Big corporations.
case, and big corporations, right?
So can we get you both to be on some night?
Both of us?
Yes.
I'll have to ask him. Then he talked about those issues and I talked about the psychology, right?
Oh,
that's really interesting.
And sort of the politics and what are some of the issues with that community.
Did you I'm sure you both read Ministry for the Future.
I haven't read it, but now that you're saying it, I will put that on.
I'm just finishing it now, and it's one of the most it's one of the most, I think, important books of our time right now. It's very powerful. It's about the interconnectedness of economic institutions, political, social, countries, and how it's shaping how our world is going. It's really fascinating.
He looks at like the political economy of the environment.
I'll bet he's read it. Barack Obama put it on his to read list. It's an amazing,
I must
scary book.
Read it. So that's some of the work. And now with the Bevy, I would like to use the Bevy with assessment, because I think, unfortunately, when I'm in an institution like I am, it's a lot about pathology. But I think to look at some of the scales that he provides and understand, beliefs and values and how they impact your personhood. That's what I'm currently trying to look at.
That's interesting.
Disseminate some of those skills and add it to some of the comprehensive evaluations I do. So.
And tell us, in the time we have left, do you want to tell us a little bit about your view of unified psychotherapy? Like, how do you use that, or how do you understand that framework?
It's closely aligned to what you said. I really found that very compelling, because that's what I really do. Right? And for example, I'll tell you, I had a patient, this was back, where he came, and our first individual therapy session, he said, I have issues with my mother and all that, but it's all sorted and I don't want to deal with it. I really have anxiety and these are my anxiety things and this is what I want to talk about. So I said, okay, let's take an ACT perspective. And
Yeah.
we did a lot of psychoeducation about ACT and, you know, and he really sort of, we had about 3 sessions and it was ACT focused. And then, like it happens, he comes in very upset because he was at lunch with a peer and she called him a narcissistic asshole. And so he was very wounded by that. And he came in and he was like, you know what? She called me this, and why would she call me that? And that then unfolds. So we did all the anxiety work, but
Yes.
then it gave us the opening to do the more interpersonal, relational,
Yes, I love it.
dynamic
So
attachment.
you took him where he was.
Mm-hmm.
Take him where he was,
Mm-hmm.
and
And
then
then it
something
opened.
happens.
Yes.
Right? And then your conceptualization, yes, these
Yes.
ACT strategies also work, but it's at one level.
Yes.
And then there are other levels of work that you have to do. So
He
those
wasn't
building
ready,
blocks that you
but
had
you were
talked
there.
about,
Yeah. Yeah.
right?
That goes a long way.
So it goes all the way. And so that's why I really, and this multimodal method, right? I taught DBT, for example. One of the groups I co-led was DBT.
Mm-hmm.
And some of the psychodynamic people find, oh, DBT, but if you think about it, right, it's very Buddhist first. It's been adapted
Oh,
from
yeah.
Buddhist,
A lot of
right?
mindfulness.
So the whole acceptance and change dialectic and what that means, right? And when you are that emotionally dysregulated, you need simple things. So it's easy to teach, but it's hard to actually practice when you're in that distress,
Yes.
that level of distress. So I would be more sort of philosophical and principled and then say, yeah, you know, this is a tip skill and this is, you know, whatever the different skills of DPT are, distraction, grounding, all that. But, and I never thought that that was somehow in contradiction to the attachment based, right, stuff. Because when you have attachment insecurity, when you're that emotionally dysregulated, you know, your sense of self comes from your sense of other, right? That's the whole attachment philosophy. Then you can understand why somebody thinks dichotomously. And so the work, and DBT gives you the language to do it very simply. Say, from dichotomous thinking, we're going to dialectical, the middle path, which is very Buddhist. So that's why I think, you know, I think more systemically. I'm just sort of more biased towards that. So sometimes I think I'm not good with nitty-gritty details. So I don't think I was a good researcher for that reason, because you have to be detail focused. I am more forest and less the trees. So if that answers your question.
It's very helpful. So we have one more question. Lizzie, do you want to answer one more question before?
I have
the recorded version in a couple of minutes after this question, and
we
then
have 5
talk a little
minutes.
while afterwards.
So you gave really good advice about preventing burnout with the team aspect and being collaborative and having a community and, you know, having your own supports. That's really big. What other advice would you give to young therapists in the field? What would you say is important in addition?
Enjoy the, you know, not bitterness, but sort of the reality of all these systemic problems, you know, and seeps in. And when I see young therapists, my trainees or very early career, just out of postdoc fellowships, I really love their enthusiasm and their energy and their curiosity, because they haven't had the experience of seeing the range of psychopathology, you know, 10, 20 years in we see, right? And that sense of wonder, or I can't believe it, is really wonderful for me, because I feel a little, not burnt out, but you know how it is?
You've
We're
seen
just
a
like,
lot.
I've been there, done that, seen
Yeah.
that.
Yeah,
You know,
you've
there's
seen
a
it
little bit
all.
of that. Yeah.
Yeah, I
So
like that. So enjoy the excitement.
enjoy the
Keep that
excitement.
enjoyment.
Keep that enjoyment,
Yeah.
because when I see that, I remember, oh my God, at one time, you know, things were tough. You were broke, you were poor, you were finishing graduate school. And so I'm not trying to sort of glorify that, those are tough, but there's a certain sense of wanting the
Wonderment.
experience,
Wonderment.
Wonderment is one of
that
my friends.
wonderment. So enjoy the wonderment.
I like that.
Well,
Enjoy.
thank you so much for taking time to talk to us. I'm sure people who get to watch the recorded version will get a lot out of this. And we hope you come back, and maybe with your husband sometime, to talk about interdisciplinary collaboration and how interesting that is, and where I think we need to go. So thank you again. We're going to stop the recorded version and we'll hang around and talk for a couple of minutes. Thank you all for watching.
Thank you. Thank you for having me. Hopefully it was helpful.
Oh, yeah.